All right, so just talking about the pacemaker action potential. So, in the heart, the way to organize this in your mind is say, okay, look, I have two types of major cells, okay? So I have my pacemaker cells, which, again, when we're talking about pacing, we're usually talking about the SA node, but we can group the AV node in here as well. So these two are going to be your primary pacemaker cells. And then you can kind of think of everything else as, your non-pacemaker cells. Okay, and there's some overlap technically because, like we said, some of these other cells can be pacemaker cells, but in general, it's difficult to just sit here and memorize all of these different, who fits into what bucket. So in general, the non-pacemaker cells, you can think of them as all others. Particularly, though, are going to be like the atrial myocytes, the ventricular myocytes. So the thing that really characterizes these pacemaker cells is the fact that they don't have any true resting potential. Briefly, for some time, we kind of reach a low here in terms of our membrane potential, but it's not resting at that level. The membrane potential is constantly changing. And so that's one of the big things to remember here is that, phase 4 of this cycle doesn't really have a resting potential. So there's no resting potential in the pacemaker cells. So there's no true resting potential. So no true resting potential. And this is going to differ from some of the ventricular myocytes, for example, or the non-pacemaker cells, which actually do have a resting potential. And the reason that there's no true resting potential is you can see as we start to, after repolarization here, right, what happens is we start to have this slow influx of sodium, which is sometimes called the pre-potential. And so this slow influx of sodium prevents there from being a resting potential. So if you ever get a question that's asking about, why are there no resting potentials in pacemaker cells, it has to do with this inward sodium current. And this is a very high yield current to be familiar with. It's sometimes referred to as the funny current, okay? So the funny current, or you'll see it represented I for current and then sub F, is referring to this inward sodium current. Okay. Now remember, there's going to be inward and outward currents, and I don't want to spend too much time talking about these because we went into these in great detail in the conduction physiology section in the neurology video, and so that would be a great kind of jumping off point if you're not super familiar with these. But just remember that an inward sodium current is going to be depolarizing. Okay, so inward sodium currents are depolarizing, and that's exactly what's happening here. We have a very slow influx of sodium. It's not like your, skeletal muscle action potential where you just have this rush of sodium coming in and you have a straight depolarization. That's not what we're talking about here. It's a very slow, gradual increase in the sodium that eventually reaches a threshold potential. It's not just the sodium that's contributing to this rise here. There's also going to be some permeability from calcium current. Specifically, T-type and L-type channels are going to open, and those are going to cause an inward permeability of calcium current. So inward positive charges are going to be depolarizing. And what these stand for, so the T-type channel is a transient channel. So T is for transient, right? So transient meaning it's not going to be around for a long time. The transient channels are really just responsible for this portion here of the curve. So the T-type, right? So the T-type calcium channel is just going to be responsible really for this portion here. But the L-type calcium channel, as you'll see in a moment, is actually going to be long lasting. So the L-type channels will be activated somewhere in here, and they'll help the slow influx of positive charge reach threshold, and then they will be primarily responsible for this rapid influx of calcium, which would be the depolarization phase. So just to recap this, what we have here is we're starting here at this point, and we have this slow influx of positive charge. There's some sodium, we have some T-type calcium channels, we have some L-type calcium channels, and they're all going to be responsible for this slow influx. The first channel to remember here is this inward sodium funny current, which is the most important channel to remember for this phase in orange here. Okay, so the most important channel to remember for that first phase is going to be this funny inward sodium current, which starts this process off. It's slow, but it's spontaneous. So there's nothing that needs to happen. There doesn't need to be cells around this particular cell to activate it. It's just going to spontaneously do this after a repolarization. Okay, so these channels are going to get activated after this repolarization phase, and then they're going to slowly kind of eventually reach this threshold. And they're going to do that in conjunction with these other channels we mentioned, these other calcium channels. Now, once this threshold is reached, now we're going to phase 0. And so phase 0 is your action potential depolarization. And this is pretty consistent, right? So phase 4, you'll see in the non-pacemaker cells, is going to be the resting potential. And phase 0, again, is going to be the depolarization. And the depolarization begins when we reach the threshold, right? When we reach that point, now we depolarize. And what do we depolarize with? We depolarize with the L-type calcium channels, right? So this rapid influx of calcium depolarization is from the L-type calcium channels. Now you can see here the sodium current and T-type calcium current, they both are going to decrease. So the primary thing to remember about phase 0, the most important thing, is that this is going to be largely driven by calcium current, which is very unique, right? If you think about, skeletal muscle, you think about nerves, those are all going to be sodium as your primary cation causing the depolarization. Whereas when you're talking about the pacemaker cells like the SA node and the AV node, this depolarization is going to be driven by calcium, specifically L-type calcium channels primarily. They're the long-lasting ones. They're going to go through multiple phases of this cycle. Okay, and that will eventually lead to action potential depolarization. And after depolarization, we have an immediate repolarization, this phase 3 here. So then we're going to repolarize. And you'll notice, you're probably saying, okay, hold on a second. We went from 0 to 3. What happened to 1 and 2? So there's no phase 1 and 2 in the pacemaker action potential. There are a full set of phases in the non-pacemaker action potential. But here we go from depolarization immediately to a repolarization state. And this is largely, once again, driven by potassium, similar to what we see in nerves and in skeletal muscle. So it's an outward potassium current, where I'm taking positive charges out, so I'm going to cause a hyperpolarizing state. And the other thing that happens here is that the L-type calcium that was the cause of the depolarization, that's going to decrease, and those channels are going to inactivate. And so primarily, again, if you have to remember one thing about this phase, it's driven primarily by this outward potassium current. Once you kind of start to get this down, you can kind of think of this in the big picture sense, right? So when we're talking about this pacemaker action potential, we're primarily talking about heart rate. Okay, so this is really what this is controlling, right? SA node, AV node, it's controlling the heart rate. So you can imagine with sympathetic stimulation, parasympathetic stimulation, that can alter this pathway completely. Okay, but also remember that there are channels, there are these calcium channels that are going to be in the myocytes as well. And so when we're talking about the myocytes, we're talking more about contractility. The point here is, if I'm talking about pacemaker cells, right? If I'm talking about pacemaker cells, I'm talking mostly about heart rate. If I'm talking about non-pacemaker cells, I'm mostly going to be talking about contractility. Remember, when we're talking about contractility, we're talking about this influx of calcium into cardiac myocytes that's leading to them being sensed by the ryanodine receptors in the sarcoplasmic reticulum, and then we get calcium-induced calcium release binding to troponin C, moving tropomyosin out of the way, so actin and myosin can interact and we can get a contraction, which is kind of what we talked about already in some of the previous videos in this series, but just trying to get that so you can organize that in your mind. Now, the last thing I'm going to add here, and this is getting a little bit more technical, but this is all very much true for the SA node. But when you get to the AV node, things are going to be a little bit different. The pacing is going to be different, and there still is this sense of automaticity where this whole thing is kind of going on its own. There's no external stimulus really to cause this slow influx of the sodium ions. In the AV node, we actually don't have these funny channels that we have, these funny sodium channels that we have in the SA node. So a lot of this is more determined by calcium. So I don't want to kind of confuse you with that, but if you're really getting into the details, that's something to know.